My name is Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis. I'm a professor of radiation oncology, where I'm chief of the cardiothoracic radiation oncology service, and as well as director of clinical trials. There are now a large number of potential therapeutic options for patients who present with brain metastases from lung cancer. It's been an inspiring shift over the years from where we started decades ago, but it also makes that decision-making somewhat complicated. So the first point of confusion for many patients is in those patients who present with initial diagnosis of brain metastases and they're considering radiation as a treatment option, which is better, whole brain radiation or radiosurgery or a combination thereof? Historically, the answer was whole brain radiation for everybody and radiosurgery for select patients, possibly as an additional boost at the end of whole brain radiation to try and enhance the effectiveness of that treatment. But over the years, we've become a lot more cognizant of the fact that there are very real neurologic deficits that can occur as a consequence of whole brain radiation, specifically as it relates to short-term memory and recall. Now, that may just sound like something that you can detect on a neurologic exam on a patient, but in fact, it has real consequences. People recognize when their short-term memory is impacted, when they have difficulty going to the grocery store, remembering the shopping list, and coming home with all the things that they intended to. They often find themselves being reminded by their friends and family of things. So while these are ultimately not life-threatening side effects, they do affect quality of life. And so we've come to a threshold now where it seems like that the pendulum has swung and we're trying to avoid whole brain radiation when possible. Now, there are times when it's absolutely the preferred therapeutic modality, but in point of fact, most people are now avoiding whole brain radiation as the first treatment when possible and trying to offer an alternative initial therapy. One of the most clear-cut potential alternative therapies is radiosurgery. Radiosurgery is a type of precision, pinpoint, focused radiation that can be delivered in anywhere from 1 to 5 treatments typically. Typically, one treatment is best for smaller lesions, and we typically reserve fewer doses. Typically, one treatment is best for single small lesions or many small, tiny lesions. As the lesions get bigger, it's better to reduce the dose per fraction and increase the total number of treatments to keep it safer. But overall, for many patients who present, even if they only have 1, 2, 3, 5 lesions, radiosurgery tends to be the preferred upfront modality. And that's been borne out in multiple randomized trials that have shown that ultimately the control of the lesions themselves at where you target the radiation seem to be roughly equivalent. And while whole brain radiation does improve that local control somewhat and does reduce the risk of developing failure outside of the regions that we targeted, there doesn't appear to be an appreciable impact on things like overall survival. And so at the end of the day, the approach that many people are taking is to start with radiosurgery, watch these patients carefully, and then in the event, which is likely, in excess of 50% in most series, that they develop additional brain metastases, you can always consider doing whole brain radiation at that time as a type of salvage, or in many cases, continue to do additional radiosurgery. The net balance, it's always tricky for an individual patient, is trying to figure out whether that individual patient is more likely to suffer negative consequences of growth of their brain metastases or more likely to suffer the consequences of the therapy that we offer. Unfortunately, none of us have a crystal ball, and there really aren't great scoring systems at this point. But I think overall, the pendulum has gotten to the point where we recognize that many patients will develop upfront early neurologic deficits from things like whole brain radiation. And as a population that's living longer and doing better with their systemic therapies, we really need to think about those initial upfront steps. Lastly, again, in this patient population, the other game changer has been systemic therapies, specifically targeted therapies. So what we know is that historically, cytotoxic therapy was really an insufficient treatment for most patients for their upfront management of brain metastases, even asymptomatic brain metastases, which can quickly become resistant to treatment and ultimately cause neurologic compromise. But in those patients who are fortunate enough to have driver mutations, or perhaps high expression of PD-L1, we know that particularly small lesions can respond quite favorably. And so in our clinic, and I think many clinics around the world as it increases over time, we're finding that in many patients, upfront treatment with their systemic therapy options, such as osimertinib for EGFR mutant lung cancer, can also do a very nice job of controlling the intracranial disease, therefore allowing us to reserve things like whole brain or radiosurgery as a salvage treatment. What we do know is that ultimately those patients do need to be followed carefully, though, because many of them will eventually develop additional brain metastasis or progression of the ones that we knew at the outset. So close collaboration with the radiation oncologists and neurosurgeons is critical for such an approach. Lastly, on the other end of the spectrum are those patients who we question whether any local therapy to the brain at all is recommended. These are patients who come in with metastatic non-small cell lung cancer, often who failed multiple lines of systemic therapy, who have a poor performance status. The default reaction in those patients has always been to offer whole brain radiation. Now, several years ago, a large randomized trial called the Quartz trial was run, which took those poor performance status non-small cell lung cancer patients and randomized them to best supportive care or whole brain radiation, questioning the tendency to use this treatment in these patients, wondering whether in fact attacking the brain mets at all even improved quality of life. And in fact, the opposite result was shown to be true. In patients randomized to whole brain radiation, they had worse quality of life as a consequence of the treatment. And so in that short remaining few months of life that they had, there didn't seem to be a distinct advantage. And so in this opposite end of the spectrum in these poor performance patients, withholding whole brain radiation, while it sounds like something that you would never want to do, in fact, actually may be exactly the right thing to do so that those patients ultimately do not suffer the negative consequences of that treatment. What becomes trickier is whether you might consider radiosurgery in this population. Radiosurgery has typically been held back as the thing that you only offer people who have high performance status, projected long-term survival because of the costs associated with radiosurgery. But as the costs of these treatments come down, as the complexity goes down, as these become more automated with all the tools we have in radiation oncology, I think often we're reconsidering these things such that we want to minimize the negative consequences of our treatment and improve the quality of life, in particular for those patients most likely to suffer those negative consequences at their end of life.